Very good morning, everyone. I would like to thank the organizers for making me a part of this prestigious conference and this informative session. Now, switching a little bit from small babies to elderly population. A lot of times in our retina practices, or even as anterior segment surgeons, when we are screening our patients for cataract surgery, we can come across this large drusenoid pigment epithelial detachment. You do an FFA ICG, there are no leaks. So I want to know the opinion of the practitioners here as to what would you do. So how many of us would like to inject an intravitreal anti-VEGF injection? No one? How many of us would do a laser plus minus and anti-VEGF injection? How many of us would observe? And how many of us would refer for some to someone who can manage it better? So we'll hopefully reach some consensus at the end of the talk. Just going to show how we managed a few of these cases. So this was a 59-year-old female with recurrent episodes of uveitis in one eye. She had developed a PSC in one eye. She has a significant history of AMD in both her parents. Both the eyes showed large PEDs, drusenoid PEDs, and all we did, as few of our practitioners said, we ruled out a macular neovascularization here by an FFA and ICG. OCT angiography also confirmed there was nothing lying there, and all we did was observe. So she was followed up for 8 years. We can see the PED is now gradually increasing in size year by year. It is accumulating some subretinal fluid at the top of it. There are some hyperreflective foci intraretinally, and the PED has enlarged to a point where finally it started to collapse. So the PED ripped on its own, collapsed, and finally the patient had a vision of 1 by 60 accompanied by a complete RPE and outer retinal atrophy. What happened to the other eye? In these 8 years, the other eye, which had also presented with this PED and some subretinal fluid, gradually started decreasing in size. The fluid went off, the hyperreflective foci went off, and to a pleasant surprise, she was 6 by 9. The PED had completely resolved, and the patient is till date maintaining a good visual function. Another patient with both the eyes PED has been following her up for 4 years. The right eye is showing some alterations in the PED height and size. When we look at the left eye, that PED again completely resolved. So we can see a near normal outer retina, subfoveally and temporally. Nasally, there are just some drusen. The vision is still maintained to 6 by 6. Another PED followed up for 3 years, resolved completely, and the vision is 6 by 6. So what do these eyes teach us about this pigment epithelial detachment? Intermediate AMD can present with drusenoid pigment epithelial detachments without any presence of a macular neovascularization. So all we need to do is observe in these patients, do serial OCTs, serial FFAs, ICGs to see whether any MNV is developing. It can either progress to an MNV, and that is when we start treating them with an anti-VEGF injection, or progress to atrophy on their own, even regress with retaining normal function. But what about this subretinal fluid? We saw there was a subretinal fluid on top of that PED. Then why don't we treat with an anti-VEGF injection? To answer this question, the big names of retina came together and came out with 3 patterns of this subretinal fluid. They said we can find it at the top of the PED, at the side, or as a drape over a confluent drusen. Now, this is not due to macular neovascularization. This is due to sheer separation of the RPE from the Brooks membrane, which loses its blood supply. And at the top of the PED, those RPE cells can no longer function. And so they can no longer pump out the fluid to the choriocapillaris. So this fluid has just to be observed. Most of this will lead to atrophy. Some may even regress, but these have not to be treated with anti-VEGF injections. Why not laser and or use with an anti-VEGF cover so that these lesions can disappear? Well, people have done that and also shown that these PEDs regress, but so have we. We didn't do anything and the PED beautifully regressed. The second thing, it is not indicated in such patients, and giving a laser or an anti-VEGF in such patients may actually increase the risk of RPE rip. So such tense PEDs, if you go in, there's high chances of an RPE rip, and it can also actually lead to a faster progression to atrophy. So now what would you do? Give an intravitreal anti-VEGF injection, do a laser plus minus anti-VEGF, observe, or refer. So we still seem to have a consensus because no one is answering. So the answer is observation. 59 years. One eye anterior uveitis. Um, no, nothing like that. She was HLA B27, recurrent episode. We will just give topical steroids. That's all. Okay.
So many of these patients, they are on some sort of systemic treatment or something which increases their is their choroidal permeability, increases their choroidal permeability. So these patients I treat with spironolactone or Aptus tablets, 25 milligram BD for around a month. I give a trial, and many of these patients respond. Once they start responding, I keep an observation, and if there is any peaking like that, I inject, and they are doing beautifully well with the latest injections like Pebismo or Eylea. They are now in current era. I don't wait. I inject most of them after giving this trial and keeping them under observation, explaining them all the things, giving them this, and I have not have any rip in the last many years.
So, that's what the paper said, that these PDs, if we do a multimodal imaging, since now we, most of us have OCT angiography or an FFA or an ICG, if there's no macular neovascularization there, we don't have to do anything for these. These will take their own course. So I'm talking about AMD patients, not uveitis. That was just
No,
that finding.
I'm telling of AMD patients only. If we leave them, they are going to have artery atrophy, because in these last 25 years, I've been following these patients. Earlier, I was not doing anything, but now with the latest injections, long acting injections, we are getting these PDs suppressed, and they are having better vision as compared to the other.
Can we have the discussion after the?
They will come down. No, 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 no. I'm not talking all, but many of those.
Dr. Mali will
We
have
are
the next.
Short of
Very short
time.
of time.
Let's hear our guest rheumatologist.
Conclude.
Dr.
Actually,
Dr.
I wasn't
Anjani.
finished.
Oh, okay.
So I just
Now we can have the discussion over
just
a cup
1
of
second
tea.
more.
Sure.
We are done.
Yeah, please.
So what we would say and what we would advocate is observe these patients, and as teenagers we were told not to puncture the pimples that we have. Ladies and gentlemen, let's not fiddle with these PDs which can actually regress or atrophy on their own.
Yeah, good. Very nice.
Thank you
message.
for your kind
Good.
attention.
Very nice.